시청자 여러분 안녕하세요.
Hello, viewers. This is the Friday lecture series on prosthodontics, and we are also looking at various different complications related to prosthodontics. In 23, the main topic is back to the basic about full denture, and today we're going to look at how to tackle complications related to full denture. And our lecturer today is Dr. Park Chan-jin from Gangneung Ulsan University. Thank you for coming all the way from Gangneung. I know this is your third lecture, and since we last met, I hear you become president of the University Dental Hospital, so congratulations. I look forward to your continued participation in the lecture series, and look forward to today's lecture. Please maybe explain what your lecture is about today. Well, I'd like to thank this opportunity to participate as a lecturer again. So today I'm going to talk about how to resolve complications related to full denture, especially focusing on the protocols that I use. So I look forward to another excellent lecture today. And if you are joining us on the live stream of this lecture, you can post questions in real time and win some gifts along the way. Especially this third anniversary of the Friday prosthodontics series. So for 3 that's been selected as a best questioner, you will the fried chicken set, or you can win lucky draw to win Starbucks coffee coupon. You have to log in on Deno site and join us on the Deno real-time chat box and agree to receive our marketing messages. Only then can you win various presents and gifts. We look forward to your active participation, and with that, we'll start with Dr. Park's lecture. So, hello, I'm Park Chan-jin, and nice to see you all again. So, the topic that I've been given is my know-how on tackling complication on full denture, and know-how seems to be finding resolutions, but not full resolution, but I'm just going to focus on conceptual protocols that I use to tackle the issues. So I'm going to also talk about 2 cases of mine. First, denture itself, I think it's about rather than how to create dentures, it's about how to adapt and dentures and make it comfortable, the dentures to the patient. So the appearance and also impression needs taking is important, but impression taking and occlusal adjustment is sometimes difficult areas. So if there is a pain from in the patient, like sore spot from the patient, then you have to see where that pain is coming from. You can resolve it through occlusal adjustment or do relief or try to manage the patient. But if the relief it can be quickly resolved, then it's due to anatomical situation. Somewhere is thick or there's a scar. So as you see in the example, with a one-off adjustment, a lot of things can be improved in such a context. So before delivery, if there's a nodo inside the denture or sharp edge, or then you can tackle the issues on the mandible and maxillary side. And with the internal adjustment, you can improve the situation. And you can sort of see where the issues coming from. And if you take impression and hold on to it, you compare it against full denture after denture has been delivered, then you can find the problem spot. Except if there is like this type of pressure, just adjustment would not be sufficient, especially if you have used the metal base from the implantation stage. You have to take it again, and you have to solve it in the impression stage. So if you went to full prosthesis stage, it's very to resolve. But on the maxillar side, inside pressure versus mandibular inside pressure, the impression material and the transparency is different. So you have to approach the two situations differently, is what I want to say. And the pain area is also very much visible, like you're biting into cheek, or if there's a scar, there might be pain. But I can confidently say I can remove a pain because anatomically it's in match, and with the adjustment, it will not solve the issue, but at least pain will go away. So PPN sometimes very hard and painful, but with the quick adjustment, it will improve the situation. And on the mandibular side, you see this buccal side situation and other side situations all can be resolved. But the tricky areas with the various cutting, it might not be resolved because it's related to the movement of the denture, especially on the mandibular side. Then you have to make a judgment call. As with the cut, making adjustment will not resolve the total situation, is what I want to emphasize. So, like, if you look at this photo, so this is a mirror image, but on the mandibular side, on the right side, on the back side of the lingual side, there's a pain, and it's a typical denture movement. And when he chews, then with the fit checker or PIP, the area that comes in contact denture, you might cut it, but the pain persists. Then what to do? It's let's see the hidden slide concept on the mandibular side. Rather than talking about the both sides cause occlusion, whether the edentulous or partial edentulous, or with RPD or its implant, whatever, the key here is the central occlusion. Then the occlusion plane, when it's closed, the synchronous contact on the upper lower is very important, because if there's no synchronous in the contact, the mandible then wants to synchronize contact, the denture moves. Hence, when you do teeth alignment, you use MIB. So synchronicity is not there. Some side comes into the contact first, and with the load there is a twist, hence the denture inside there is a scar or pain. So on the left side, the red mark, if there's a contact but there's no contact on the opposite side, on the right side, if there's contact, then if the load is put into making contact, there's a twist. And then, as you see on the right side, the denture cannot but move to be closed, and mucosa is hit, resulting in pain. And this is the hit and slide concept you learned in the school. So to adjust that, you take the impression and then you do occlusal adjustment. Occlusal adjustment is not about creating BBO. So in these lectures, I always emphasize synchronicity. Synchronicity here means when you close, you have to close it together all on the posterior side, be it full mouth or edentulous patient, whatever the restoration. This is the key concept. So obtaining this, be it full denture, especially for the edentulous patient, you have to do the clinical mounting. So you need this type of contact mark in many places. You see on the right side is the key to solve the issues. So the appropriateness of the occlusal plane and is also the key, as I said. So if you delve a bit further, relining is about appropriateness, so I'm going to talk about with cases. But here, in internal contacts, with the checking contact, you use PIP and fit checker. So let's look into them. As you see in this slide, on the left side, fit checker is silicone in material. So base and cartilage, if you mix it together until there is polymerization, there is a certain thickness. But the issue here, on the upper side, if you cover it on the maxilla, everything, the excess is closed, kept in here. So that's not good. So you should not use on the maxilla overall. PIP is the only one because it's cream. So you brush it on the maxillary side or mandible or whatever, and how it's the way it's brush, you know where the point is, and that's how you find where the load is. So on the maxillomandibular side, you pencil the points and check with the PIP if it's overall. This is for internal adjustment. On the mandibular, again, PIP is used and penciled in with the marks. So here, this is fit checker use, and as I said, partial adjustment can be made with the fit checker. The thickness is there, especially on the polished light or the border. The thickness, the locally it's much better fit. On the mandible, you can use fit checker overall because the excess can be removed easily. So the maxillar internal overall adjustment, the fit checker should not be used, only for partial adjustment. So this is the sequence. The border thickness is adjusted with the fit checker in the sequence of the ABC. And this is the table I refer. So on the maxillar side, overall it's inadequate, but on the polished area, limited usage, and over other areas, it's okay. So you have to do good analysis and adapt the way in the real cases, and whatever the material fit checker or PIP, you can use that if the conditions are met. So as I said about relining, due to time constraint, I'm going to talk with the cases. So the key is, if the internal adjustment occlusion is good, then occlusion adjustment should be the final goal in your protocol. So it's not about doing the adjustment very well, because the occlusion adjustment, technician can do it for you, and for dentist, actually remounting is what you need to do very well, and that's what I want to emphasize. Remounting is the key. So check bite, doing again 2 millimeters of check bite is my recommendation. So here, it's not 4 bites, you make 2, and maxillar you took 1 and mandible took 1. Just make it not too transparent. If it's too thick, of course it could result in errors. So again, 2 millimeters should be the optimal thickness. Hence, making adjustment. For me, I'm already familiar with this, but for you, it's better to let the technicians do it. So in the central, midline, upper and lower, you don't see much of the marks. You have to therefore create it like what you see on the right. So hidden slide phenomenon sometimes is inevitable. So clinical remounting, if you do it frequently, you become more confident about the result, and patient would have synchronicity and become easier in terms of chewing. So clinical remounting in the beginning, it might be, not easy to do, but once you gain experience, you become confident on your skill. So I strongly recommend it. So here, clinical remounting, it's a textbook MI on the light left movement on the right side. That's what you see here. So in the textbook, the point you see at the clinical remount, it disappears unless you do T alignment again, because midline shift is so frequent, so principles change. So what I think is that textbook principles in the real world situation, the posterior the goal of clinical remounting to synchronicity is per teeth more than 1 point. That's synchronously marked. That's more useful in the real setting. So why it's better to let technician do is, as you can see in this slide, the errors you see, there's often this type of non-contact, especially if there's a midline shift. So adjustment is not enough. You have to do resin buildup or teeth rearrangement again, but it's very hard to do yourself. So it's better to let the technician do it. So, you take the intermaxillar check bites, and depending what you want, you choose different approach. But again, you take the check bites and ask the technician do it. I think it's less stressful for you dentist. But this is what you need to send to the dentist. With Elogas, you took the bite, but with only bite, when you assemble again, there might be bend, and it might be different when you deliver to the mouth. So maxillar mandibular, you take it off again simultaneously, and with the spatula, you melt it with alcohol lamp. On the lingual buccal, you melt it completely. Then with the chilling, it becomes hard. So without the model, you can send it to technician. Still, the similar relation as in the mouth will be maintained, and I think that's very important. Let's look at actual two cases. Now, for this patient, 11 years ago, I created and didn't come back to me again, but I also did his restoration, but there's a discolorization now and a bit of flexure inside. There's a fracture again, but with the interesting, the occlusal plane did not wear that much. However, inside the mouth, you see the stomatitis, and there's less propiness, and it's become too loose, they said, the denture. So it's a severe complications, and you see various complications for this patient. Very easy to use to teach students of this patient, because there are many complications you see here. But as I said, you can do with the easy treatment and correct the situation, but in the slide being thin, especially on the maxillomandibular side, if you see the arrow area, it should not come into contact. So internal adequacy is not longer there, especially on the posterior side. Although there's not much of a wear, the anterior side, you see the occlusion not being very good. So there's a lot of twists, and anatomically this results in various complications, and it had also this type of complications. So you have to block it inside. You have to increase vertical dimension, and you heal it with various realigning, and with that, you see, using the patient's occlusal force, you say dynamic impression taking, and within the relining, the case was finished. Well, can I ask you some questions? Now, when you do relining, you seem to use indirect approach. But for many dentists, when they use indirect relining, get the denture again, do the various adjustment again. But for direct approach without occlusal adjustment, they sometimes, not do that. Would that be okay? Well, I don't know whether this would be helpful, but I just summarized in one slide. This might be the perfect answer, but on the left side, this is direct approach. On the right side, it's indirect relining. And the top left, its light body was used, very easier approach. On the bottom of the left, you see dynamic approach. So two things I want to mention here. In terms of material, it's very important. If you do indirect relining, the material is softer, so there might be some damage. And in terms of occlusal adjustment that you talked about, local adjustment, direct relining is okay, but overall adjustment, the occlusal force cannot be trusted. Hence, in some area, there might be imbalance or there be thickness in some parts, so you have to do it separately. Occlusal adjustment is what you also need to do. So you have to do it, and of course check afterwards again. I also agree to that point. Thank you for that answer. Now, look at the live chat box. Thanks to high interest, there seems to be a lot of questions also. And it says, Professor Joe, Professor Park, look forward to your good lectures. And we also have, I really enjoyed Dr. Park's lecture last time, so look forward this time also. And then we also have, look forward to a good lecture. And also, ID Smile again, Professor Joe, Professor Park. I'm also participating in this lecture series. Looking forward to your lectures. So there's a lot of comments congratulating on the 3rd anniversary. And we also have Friday lecture series fighting. Look forward to good lecture. So there's a lot of words of encouragement for us. And thank you for all the nice comments, and hope that this series would continue to grow so that you will enjoy them more. So of those that posted words of encouragement, Nangyang Punchy and Wise Dental Life, I will send you coffee coupons. Thank you very much. Besides that, there are a lot of people that expressed congratulations on our 3rd anniversary. There are different things you can win from Lucky Draw, and the questions that you posted after the lecture, we will try to answer them. So please continue with your lecture, Professor Park. Well, we will look at another case. Now, a dentalist patient, and again, also here, there's a lot of bone resorption. So there was a denture that it came with. Adhesive was used, especially on the mandibular side. The appearance was inadequate, so we created a new denture for the patient like this. Now, after we had follow up every 1 year. He came very frequently and, according to the schedule, and it went very well. But on the right side, on the lingual, there was an ulcer, so there was pain. So this was something that did not happen. Happened 7 years, so we have to do relining and do adjustments. So these are some of the signs that treatment is necessary. So occlusal plane of the patient was still good, so I think it can be used again. So used lining material for the maxillary side to be used for certain time. So the pain was healed because we blocked it, and direct alignment, and again occlusal adjustment. So like clinical remounting that I talked about, that the adjustment synchronicity was secured. And I said before, as you would sort of guess, per tooth, it's not ideal contact mark. So in the articulator, it's key to have synchronicity. So midline is a bit twisted, as you can see on the top right side. But on the posterior side, there is always one mark per teeth at least. And with that, as you can see, ultimately where there is a force, it's always on the posterior side. So RMP on the left and right side, especially on the front side, repetitively he said there was pain. Then the occlusal relation was clear and there's synchronicity. So hence, simple internal adjustment is only what's necessary. And I do believe that's very dramatic. And that's what I wanted to emphasize. Now, within time, there was time constraint, and I tried to move very quickly, but I hope it's been helpful to you. But again, if you have good appearance, then, adequacy or appropriateness needs to be secured, and how to increase that. You need skills to increase that, and basics you already know. And the occlusal area or plane is more important than you think, but we do have to use check bite, send a technician clinical remount and, ask for adjustment to the technician. Then, of course, it will not solve all the dentalist patient issues, but are you going to manage or do adjustment? You can distinguish in your protocol and approach with that and have a successful result on your hand. Thank you for a good lecture and very clear and succinct ways to explain how to resolve complications is what we learned. So thank you very much. And I think we have now today a lot of time to answer your questions. So thank you very much. Well, then, let's look at some of the questions that's been posted on our website. There are too many questions today, so only that's related to today's lectures will be selected to be answered. So even if your question is not chosen, please do not be disappointed. Now, the first question we will look at is what is way to check the most frequent sore spot of the full denture complications? I think it's a good question, and I do believe that's a key question of the day. But basically, what you think is that the appearance would be, let's assume, to be adequate. Then opening and closing repetitively, you let the patient do it, and if there's a twist or not, first needs to be checked. And after that, if it's adequate opening and closing, then internally fit checker or PIP you used for adjustment. If there is a twist, but then fit checker and PIP becomes useless because it's about occlusal surface of the full denture. So the source of it is about adjusting the occlusal surface to make correction. So again, occlusal surface needs to be stabilized first before you check the fit check, whatever, to check the sore spot. Okay, yes. Now, congratulations on becoming president of the dental hospital. Maybe it's your former student. Next question is from the same person. So those that have severe flabby tissue, is it better to create denture after surgery anyway to prevent flabby tissue? Well, today we're talking about full denture. Now, to prevent flabby tissue is, I think, for general cases, the anterior mandibular side hitting the maxillary side, resulting flabby tissue, then implant would be the best option. But still, when there is flabby tissue, then doing full denture surgery, there's no vestibule, so you cannot really opt for surgery. So only creating open tray, and that's about impression stage. So that's something you need to learn more through the textbook, but that's only about managing the posterior area. And I think it doesn't resolve your difficulties. And another issue or question that relates to complications is not related to this, so we'll skip the question. Next, if there's a big bubble while taking impression, then you add the material only on the bubble. Would that be good? Oh, that's a good approach. So if there's a big bubble, even I think there's a assumptions or preconditions. I think I also did lectures on impression, but the key is consistent thickness. I think the first mistake is you use too much of the material. So you have to use less in volume. So you move it to the border molding, the relief, that's only what you need. So you have to use small amount, then you can have a clean result on your hand. But still, you have a big bubble. Then, as you said, you add impression material only in the bubble and reposition it. That's it. So you already know how to tackle that situation. KS says, is it sore spot due to occlusion or to inadequacy of the different reasons. How can I tell it? I think it's already covered in the lecture. So the denture that I create, you have to be responsible until the end. But for cases that you've been referred to, you also need to be careful. Again, open and close, and if posterior comes in contact on maxillomandibular side, that should be your starting point. Yes, after realigning, if the patient still think it's uncomfortable, then use soft lining. But if it becomes harder, then doesn't pain recur? Well, it's also another topic that I like, but maybe he listened to my lecture beforehand, because this is a topic that I only lecture in Korea. But anyway, if there's more opportunity later on, I'll talk more about it because it doesn't really relate to today's topic. Okay. So flabby tissue issue has already been mentioned. And then next question, for internal adjustment and for occlusal adjustment, how do you difference between the two? How do you know which one to do? You use look for hidden slide. Okay, so it says denture comes off when there's vibration on the ceiling of the mouth. So on the upper side there's a natural teeth. And there's a difficulty in doing maximum sealing. So how can I solve that with the full denture? It's a tricky case, it seems. So I could give you at least some tips. When you make denture, if I may explain. So when you make the denture, yes, it also relates to complications, so do explain. If it's natural teeth, occlusal plane, if it cannot be corrected, there will be limitation, and that's important fact. You know, whether you're using metamaterial or whatever, that's not the important thing. On the mandibular side, occlusal plane, if it's irregular, then, you know, no choice. And the full denture itself, up to the back side, if the natural teeth that does not come to contact, it's again very difficult. So natural teeth at least needs to be up to number 7. And when you take impression, what we sometimes ignore is that when you do border molding on the distal buccal side, on the upper side, there might be big space. And then in border molding, when we create working cast, the thickness cannot be copied very well. When you put the full denture, you might have had thickness in that area, but when you see the final result, it becomes very thin. That's the final result. So you have the occlusal plane is adjusted because of the opposing natural teeth, and it becomes off when on the vibration in the ceiling. I think that's that area. In the hemular notch on the both sides, you have PPS and hemular notch. And hemular notch, this distally, it's rotating area, the space, sometimes people have big space. So if the edge thickness there is thin, then that might be resolved. So please check the thickness. Okay. And another question, ultimately, occlusal adjustment needs to be done outside, and articulate face bow, is it a must? Well, here again, it's also my favorite topics, but it seems like expert is asking those questions. Yes, today's questions are also in alignment with today's topic. You don't have to use Facebook. Makusa does its work, and patient can adjust. And you don't really need even semi-adjustable articular. In articular, what's most important is the big side. You have to be at least head size rather than small sides. If it's average articulator, you have to use a big one. So not small articulator, but big one, at least your head size, okay? So PIP material, what is that? I think it's from Crown or something. So it's a cream product. In the past, when I lectured to the students, there was no PIP in Korea. It was in the textbook, but not sold in Korea. So I mixed oil with the tinkoxide, tried to recreate, and I think sometimes it worked. So I learned one thing from you again. Okay, another question. Only use fit checker. That seems to be answer. So fit checker, there's a lot of loss of volume. So PIP is better. Yes, PIP, it's more burdensome. But brush, you could use toothbrush as the brush, and there's no know-how needed, and you can just swipe it off with the alcohol. You just brush it and then swipe it away with alcohol. And I like your voice, so look for to good lecture. It's ID is queen, so it must be a female. Commenting it anyway, and then the torus amplification, there's a pain on the sore spot, so is it better to realign on the rich side? Well, it's depending on the size. If big, you have to do surgery, and it's different whether it's maxillar or mandibular, right? Yes, of course, different things needs to be considered. So if it's small inside, you would do some, but if it's big, and for small size, again, a lot of relief might be necessary because the denture moves around, right? So actually, even if it's small, you have to be careful. If it's a bit big, surgery might be the only option. So this is very helpful seminar. Congratulations on the 3rd anniversary. Thank you. So maybe this person checkboard, iced coffee coupon, we can send one. He says it's very helpful. Thank you. Now another question from the person that already exists. Ask a technician for the mounting. Well, I do it myself. From the beginning, I did like doing clinical remounting. So my target always is 20 minutes. So it takes a lot of time. In other words, you let the patient wait or no, before next appointment. So Captain Americano says, if there is fungus due to denture, what do you do? If it's severely damaged, then you have to block the mucosa, and you use soft liner to block it as a material, then it heals naturally. Or if it's severe, then you have to refer to oral surgeon. If it's natural heal, then you do with the indirect relining. So soft reliners and switch to what you used before later on. Yes, you could do that. And also Prost says, because of relation to opposite teeth, if artificial teeth lines to the buccal side of ridge, chewing with the posterior teeth results in denture damage. So how do you respond to the reducing cusp angle of artificial teeth or align to the edge as much possible? What do you do? Well, that's a good question. I do believe you know the answer because it actually happens fairly frequently. So the question itself is, it's very challenging in dentalist patient. So it's about reverse of the resorption. As there's a resorption, mandibular becomes bigger, maxilla becomes smaller, and restoration needs to happen more rather than less. Then you have the contact mark needs to be more, move it to the lingual side. Then it means the buccal side, it opens up on the outside. So without securing buccal overjut, it becomes less to chew your cheeks. And that might be one way. But if not, well, but cross-bite might not be so lingualized occlusation. Occlusation is your recommendation. Yes, you can do that. And so I learned a lot. Thank you for important tips. And I think I already talked about we move it together. Because it's and you melt it and attach it again. Remove it together. So with the bite, if there's a separation of maxillar mandibular side, there might be error involved. So you have to remove it together. So after using tissue conditioner, send the technician to do work. would that be okay? So of course you need to do it right away. So if you use 1 week, it becomes hard, tissue conditioner, because but of course in the textbook it says 24 hours, days, but in real life after using 1 week I do light wash. Then it's the approach. So the denture adhesive, what do you think about that? Well, I'm not negative about using the adhesive, but I do not use it because it doesn't really upgrade my skill, but it's about quality of life of the patient. Hence, I'm not opposed to it, especially even the US has adhesive guidelines. So it's about patient centric. So I'm not using it, but if there's a question about it, then how to use it cleanly, I can talk about it, and even brochures or guide that's related to, I also recommend it. And also copying about dentures, I think it's a bit slightly away from today's topic, so I'll just skip that one. Thank you for this good lecture series. Thank you, Professor Joe, and to the production team. So there's a lot of question with the person. This I have a question. So when there's a occlusal adjustment, the technician, is there a standard that use on the posterior side, 1 mark per tooth and not to come into contact on the anterior side? Anything further to request to the technician? Well, if I think he has a very good questions, and it's a hidden hand guiding us in certain direction because he's really asking core things. But let me talk about how I approach. Basically, my thinking is this: patients. I mean, I don't believe the impression that I take. The bite that I take, I always check and again check what is accurate to the patient. Even I did clinic remounting, it's always different. Results changes every time. So in mouth, you close it synchronously, and it's very important to have synchronicity. If you chew 10 times edentulous patient, up to 10 times it's smooth, then you can swallow it. But you chew it and if there's a kind of distortion, you cannot move to the next bite or chew. So clinical remounting, it's effective, but I don't believe on it every time. So considering all this on the anterior side, as you say, it should not come into contact. But from the get-go, with the teeth arrangement, vertical overlap, I always put it to 0 because after adjustment, there's always more overlap. So I start with the 0, and over that, 1.5 is my starting point. And even that, if there's a shift, then this becomes smaller and overlap becomes tighter. So ultimately, as you said, anterior, you have to have no contact. So valid LOX, and you have to cover, of course, premolar and molar, right? Okay, yes, of course. And Professor Park, C. Wolf is saying, Professor Park, thank you for a good lecture. Well, thank you. And Info Elementary says, any know how to create mandible full denture well, and what did you use to gain retention in your last case? Well, basically, retention wise, the patient factor plays the most strong influence. So the tongue position, the technique would be to do well, the appearance. Denture appearance needs to be in your mind. That image needs to be in your mind. So whatever the patient, this is the form of the mandibular denture that I need to create. And with that, you need slightly adjust for the patient. And for the last case retention, it's about stability of the occlusion. And there's not much of retention. It's not something that I can create. You need the good appearance. If the patient is comfortable, then with the stability, then you have it. And stability is key for chewing. And that's how you need to understand. Another question is using tap doing adjustment or not. I think that's a correct approach. And Shindram is saying in denture restoration, inevitably on the posterior side, the opposite occlusion, if you do that, then due to severe retraction on the upper anterior side, you don't have over depth, then what do you need to do? I think you would know already the answer. So it's the arrangement or alignment is not important. You just meet set of conditions. You just stabilize when it's closed. That is the key. So you have to make it usable. Denture, if it becomes synchronous, then for the patient, when he chews, when there's force, then at the same time, coming into contact is key. It hasn't really to do with the teeth alignment arrangement. Now, Dr. Guide asks, in case of metal denture in rebasing, how to make metal part attached to the resin. It's one of my lecture part, and I also talk about primer. But what you have to think about is the resin and metal does not attach in relining, so you create a large rough surface through sandblast. Then metal becomes black, but it's no chemical bonding, so metal primer needs to be used. And metal primer is for non-metal and metal had separate in the past, but now there's small primer where you can use for both. I think it's metal primer, different types of product. You can look it up. And the tip is you can also know the chemical properties of sandblasting, and you have to use metal primer, and then you top it with resin. And then the patient had resorption of the bones because the denture was not a fit. So anything to look for in the over denture when there is not much of lower anterior bones left. So I think it's about implant over denture. I think both cases might be possible, be it a full denture or implant. So I think on the posterior side, maybe there is teeth, therefore they go for overdenture. But anyway, be it implant or not, the option seems to be overdenture. So let me answer, thinking it's an implant overdenture. So it's my own subject opinion, so I might be not correct. But for a lot of excessive edentulous bone resorption, overdenture with 2 implants on lower upper parts, they say it's a protocol that needs to be used first. It's been emphasized for many years, and we did that type of treatment a lot. But nowadays, with the recall of more than 15 years of follow-up, what you see is 2 implant on lower side. Then it's better than just using the denture, but they try to eat with only the 2, and there's a shift in contact on the anterior side, and you have to make adjustments. And then anterior is the only one you want to chew because you have some senses there, so denture becomes unstable. Then for me, I have to recover it, and so you have to address it again. Hence, nowadays, as you know, in the past, when with the 2 rather than doing overdenture with 2 implants, although there's no data available, 2 implant for surveyed crown, class 1 RPD. So RPD, IA RPD is what you talk about. Yes, I think that might be the better approach. That's my subjective opinion. So as was asked, anything to watch out for? Not really. You just follow the conventional protocol, and then there is person that has a frequent fracture. What to do? Even with the occlusion on the posterior side, still there is a central midline fracture at least once a year on the maxillary side. What to do? Well, I think for this case, it seems that typical it's about anterior occlusion, especially for single denture. You have frequently like that, and then you have the lower implant and upper full denture. This is mostly case, especially angled fracture. It's related to the occlusion on the anterior side, but here occlusion only on posterior side is what the doctor did. Then it's very, I think we need more information. So probably there is a bending moment, or mid and palatus side is hard, but on sideways there is a bit something's becoming loose. Maybe that's the case. So in my opinion, maybe relining could be an attempt. Yes, it might be. So I think if there were more explanation about the case, I would have been more helpful. So it's a rare case for sure. And then out YSKHK says up to number 6, implant restoration was done. So do I need restoration up to number 7 on the lower side? Well, I slightly answered that it's a single denture. So for single denture, you need number 7. Okay. And nice to meet you, ID. It says denture seems to be stable. Bite was okay on the posterior side, but it keeps chewing on with the anterior teeth, and it says it's very uncomfortable. What to do? Well, so again, this is something I also thought about. So you have patient that in the past, if you before using the denture, the natural teeth remaining on the anterior teeth. If you have that, especially when you use the denture for the first time, you see this case. And secondly, whatever the case, anterior contact volume, the clearance volume is not sufficient. And because of that, so even there's a contact with the front side, yes, so you should have a lot of clearance on the anterior side. For both cases, you need sufficient clearance on the anterior side. That is what you need to do. So TS also saying thank you for the answer. And then KATW0103 says there's a where there's the denture on the maxillomandibular side, it's become flat, but due to insurance only create a denture for the mandibular side. What should I do with the vertical dimensions? As the upper part I can only do in 2024, but vertical dimension is already very low. So for this type of thing, what kind of artificial tooth do you recommend? For artificial teeth, I think there's a lot of compression, and even with occlusion with the natural teeth, there will be force. Of course, there might be some tear and wear. So I think the strength is there, or the force is there. So for this case, without touching maxillary side, there's not much of what you can do. But what is most important is a bit. I think there is a limitation here, but I think the point is vertical dimension. You take, you try to watch out for that. But for full denture, you need stability and occlusal plane. The angle is important. In the fixed vertical dimension, can be flat, or it could go down, or it could go up. But occlusal plane, it's going down on the back part is the worst case. So on the upper part, it's really a worse situation. Then correction needs to be made before moving to the next step. That's important. So lower part will be done first, and maxillar will be done next year. So you need adjustments there. Yes, we'll do that. But for example, in the mandibular side, like full flat, then on the maxilla it becomes full flat too, so it becomes vicious cycle. So I think you need to explain to the patient and that it's better to do both sides at the same time. And in the occlusal adjustment, if you're going to do it next year, even if there's uncomfort, then on the mandibular side, I don't know whether it's case if you're using cusp, then you remain some, so you can use it next year, but not really full flat. Yes. Next, Monte Cristo V says, thank you for a good lecture. For patients that are using temporary, cannot adjust because it's too painful and it's doesn't fix in its place. So you don't do the final denture in case of this. I don't do final prosthesis for this. So temporary is also denture, and temporary should not be really in very low quality. Like there could be the form and shape and borders all needs to be adequate, even if it's temporary. But still, the patient can not adjust it, then in the final prosthesis, of course, occlusion would remain, but you have to adjust yourself to the even temporary first before moving to the next step. So remounting, while the remounting in the technician, patient stays eventually, what do you do? So, well, you only need 1 day. Is it always 1 day? I always make it so that I can return it after 1 day. So you need a good relationship with the technicians or lab so that it can come quickly. But I think 2 or 3 days was sufficient. But of course, the issue might be you take the bite and get it to the lab, but if cannot be adjusted. So in the midline shift, sometimes that happens often. So the midline shifting on the 6 to 7 central incisor width is 6 to 7, then I only have a half, within half. If it shifts, then 2 to 2.5 millimeters occlusal adjustment can be made. But more than that, mostly teeth realignment or alignment needs to be redone, or the denture needs to be created again. So you need to be careful about them. And again, Monte Cristo V's question is slightly off topic, so I'll just skip that. And shock ID said sometimes the denture patient says bites into the cheek without using cusp. Is there any other resolution? Again, on the lingual occlusion I talked about, cheek bites or chewing, textbook guide is buccal objet is insufficient. So if you cannot change it, then you have to open it sufficiently. So on the maxillary side, maybe buccal type of occlusion is what you need to think about. So buccal side, maybe covering it up might be okay. Yes, on the maxilla maybe. And then in case of maxilla full denture, if patient finds nausea and vomit, what to do? So if how to resolve that? Actually, in testing out and in bite taking, if there's a nausea or if there's already denture might be problem and patient really complains about discomfort, then indirect lining is something I consider. So PTS is always resin for me. I don't really use metals, and one of the reasons is because of this. So you have to do shortening, but compromise the patient with the rubber. I don't do denture up with rubber continuously. Is it okay? Is it okay? I always check. So you go slowly, right? Yes, step by. If it's not, I give up. Then you go to implant, do bridge, or open palate denture would be your next option. And then Shejong Top, to check sore spot after completing denture, do you make patient also wear during nighttime? No. Well, the environment has changed. So I'd say use the denture that you used before if you cite discomfort. It's about increasing tapering. Hence, for the new denture, adapt period. During that, if you think it's discomfort, don't use it. So you just increase the time with the new denture continuously, and of course you check the occlusion and do some adjustment. So if you find discomfort, take the old one. So slowly increase the time with the full denture. Okay, I understand. So, and then you says tutu placement and doing RPD. Do you mean number 6 and 7? As you said, on the anterior side, if the patient only bite on that, what to do? Any way to prevent combination syndrome? Only way will be to do occlusion adjustment through frequent recall. Yes, I think you have answered. But if you have good ridge, then if there's a lot of resorption, then you cannot have on the posterior implant. So you might be combination syndrome. But anyway, number 3 and 4 are the positions you should look for to prevent combination syndrome. Then on the posterior implant is like the original or the first thing you need to think about. Also, Osstem says remaining teeth is cross-crossing. So having the occlusal plane flat, it's very hard because of the location of the opposite art. What to do? Well, there are different ways. Tempest line, and in the mouth, a retrobulbar pad can be used. And also on the model, havilar notch and cellular papilla extension could be used. And if it's not elderly patient, papillar side or by if there's a existing bite, then the chewing scars could also be checked. But for elderly patient, sometimes there's a lot of change. Then of course, as a textbook approach, Kemper and neutral path too. Anyways, thank you for a good lecture today, and Q&A session has been very helpful for me too. Dr. Pa, thanks for finishing your lecture so early. We were able to answer all these questions, so I'm very glad we were able to do this. Me too. Well, thank you. Thank you for the answers. And again, those that participate in the chats and post questions, thank you so much for your participation. And now, we need to select best 3 questions of this lecture. So maybe Professor Park, you could choose those 3. Well, there are many questions. It would have begun if we could give all the present to everyone, but we only have to choose 3. We can only choose 3. So first one was the one that asked a lot of questions. I have question. And second winner would be Captain Americana, and third is Prost, who asked about occlusion. Yes, Prost. Okay. Well, these are the lucky top 3 winners in terms of posing good questions. So I have a question, Captain Americana and Prost. So congratulations. And we will send you fried chicken coupon via text on Monday. And don't be disappointed if you are not chosen. We will have lucky draw for those who posted comments and give out Ice Americano coupons. Well, thank you for being with us today. Any closing comment? Well, I'm not the master of full denture, but I have delivered some lectures on that, and I think I'm confident because I'm not the alone facing these problems. Because when I do lectures, I could see other doctors having same problems, other dentists having same problems, and their age was not that, I had not much of a senior experience, so I felt confident. So again, study a lot and focused on having stable and consistent result, then you might not have all the answer, but in some areas you will be able to find resolutions. So yes, you have to practice a lot clinically so that you become comfortable with your skills. I think that was a very key point. Thank you again for today's lecture. And Protodontics on Friday. I hope that you enjoyed today's lecture. It's about full denture complications, and I hope that it's been helpful to you. And if there's any question that we were not able to answer, we will use the comment section to answer them. Next lecture will be about immediate denture, will be delivered by Professor Baek Jang-hyun. Thank you very much for being with us until the end. Thank you so much.